Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. Tonight's webinar has been scheduled for an hour. However, the content from our experts may just exceed the hour mark, and then we will hang on for a bit for live Q&A. Therefore, you will be earning 1.5 CE credits this evening rather than our original 1 CE credit for those of you who remain online past 50 minutes. Your certificate will be emailed within hours of the completion of this talk, so be sure to check your spam folder. You are all muted, so there's no need to worry about background noise, and we will have time at the end for questions. You can submit those questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available for free self-instruction CE at the web address that you see on your screen, elevateoralcare.com/elevatingcare. Be sure to bookmark this page and return often to see what's new in free CE. Also, if you have a topic that you would like to see covered, please feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. Although we've provided some great CE courses on the medical management of caries and Silver Diamine Fluoride that you can view on demand for CE credit, Silver Diamine Fluoride is still a heavily requested topic. So this evening, we are excited to bring it back to the basics for those of you who have always wanted to implement SDF, but just don't know quite how to. Tonight, our experts will go over the basics of when, how, and who can apply Silver Diamine Fluoride. This evening, we are honored to be joined by Dr. Michelle Kelman, Dr. Brooke Fukuoka, and our very own Steve Pardue. I'm going to introduce each of them to you first, and we'll begin with our webinar. We're going to start off introducing you to Dr. Michelle Kelman. She's a pediatric dentist dedicated to exceptional pediatric and special needs oral health care in a caring, positive, and educational environment. In 2008, she founded the Pediatric Dental Center in the Cedars-Sinai Medical Towers and was director and chief clinician from 2008 to 2021. She's been on medical surgical staff at the Cedars-Sinai Medical Center since 2008 and was the pediatric dentist for the Cedars-Sinai craniofacial team. She is currently a lecturer and clinical faculty at the UCLA School of Dentistry, Department of Pediatrics, and served as an adjunct associate professor in the Department of Pediatric Dentistry at the Herman Ostrow USC School of Dentistry. Focusing on conservative and multidisciplinary care, she has lectured and consulted internationally to general and pediatric dentists and pediatric physicians on incorporation of pediatric dentistry and modern pediatric dental techniques into her practice and the treatment of the medically compromised patient. With her advanced expertise in a large scope of pediatric and special needs dentistry in private practice, the operating room, and working with multidisciplinary teams, she has acted as an expert witness for dental-related cases over the years and as a dental consultant. She's also on the medical expert team for whattoexpect.com and kidsinthehouse.com, along with other parent-focused websites, and has educated parents with medically compromised children on oral health preventive dentistry. Dr. Kelman received her Bachelor of Science degree from the University of California, Los Angeles, and her Doctor of Dental Surgery degree from the University of Southern California. She is a recipient of the USC Behavioral Dentistry Award for Outstanding Humanistic Qualities in the Treatment of Patients and the USC Award for Outstanding Achievement in Pediatric Dentistry. She completed her residency training in pediatric dentistry at the Mount Sinai Hospital in New York City in association with the Mount Sinai School of Medicine. We're excited to learn from you in just a bit, Dr. Kelman. Now I want to introduce you all to Dr. Brooke Fukuoka. Dr. Brooke is a passionate speaker whose primary focus is improving oral health for patients who have special healthcare needs and geriatric patients who live in long-term care. She has practiced in a diverse array of settings and has built programs to help expand access to care for her patients. In her part-time private practice, Your Special Smiles, she practices portable dentistry, interdisciplinary hospital dentistry, and teledentistry, and has developed a professionally aided home hygiene program in 2 long-term care facilities. She also works full-time at a federally qualified health center, Family Health Services of Idaho, where she runs their advanced delivery dental clinic for patients who have special healthcare needs. She is active in organized dentistry and enjoys working with diverse groups of people. To learn more about Dr. Brooke, you can look up her CV on her website at www.yourspecialsmiles.com/book Dr. Brooke. And then lastly, but not least, I want to introduce you all to Steve Pardue. Steve Pardue is a University of Florida graduate and began his dental career in 2000 at the age of 22 with Omni Oral Pharmaceuticals and later with 3MSD. Steve has been a part of launching some of the best known preventive products in dentistry and is a member of many professional organizations throughout dentistry. As a managing member of Elevate Oral Care, Steve is able to develop leading preventive dental therapies and share them with dental professionals and patients worldwide. It is Steve's responsibility to listen to your needs as clinicians and patients and to teach our team of preventive care consultants how best to be save patients' natural teeth is paramount to dentistry's future, and we are working to achieve these goals. We're excited to learn from the three of you. We're going to begin with Steve. So Steve, go ahead and take it away.
Thank you, Haley, and thank you everyone for allowing me to speak to you today. My name is Steve Pardue, one of the managing members here at Elevate Oral Care and also the scientific officer for the organization. I'd like to take a few minutes before we hand it over to the presenters this evening and just walk through a little bit of the background of silver diamine fluoride and how it got to the US and some of its common uses and things that you can do with it in everyday practice. So to begin, let's go through some of the history. Silver diamine fluoride was first developed in Japan in the early 1970s. It was developed by a researcher that did their thesis on silver fluoride and silver containing products that are used in a process to stain teeth there. During that time, they realized that the individuals that had their teeth stained using a silver compound, they didn't get tooth decay anymore. So this thesis proved that silver diamine fluoride was in fact an effective tooth decay prevention or decay arresting material. So the first commercial product became available in 1972 in Japan and then gradually spread through various countries in Asia, down through Australia, and then through some of the work that was done by Dr. Peter Milgram, Dr. Mike Shirtcliffe, and several other various individuals. In 2014, the material gained its first clearance into the US, which led to the first commercial product being available here in the US in early 2015. Throughout the world, there are numbers of different claims available for silver diamine fluoride. In the USA, we have it cleared through the Food and Drug Administration as a dental hypersensitivity treatment for use in patients over the age of 21. However, here it's more commonly used off-label as an arresting agent for tooth decay in patients of all ages. Around the world, there are a number of different claims. In Canada, they've got a great example of a number of different claims that you see there on screen. And in most of the different countries scattered through Asia and Australia and some places in Europe, it's available as a caries arresting agent as an on-label indication. But we have significant amounts of peer-reviewed literature, clinical trials that show it works for sensitivity, it works for arresting lesions, and there is an emerging body that shows it works for preventing new lesions as well. Some of the advancements that we've had with silver diamine fluoride is Advantage Arrest is the first product to apply for and receive breakthrough therapy designation through the FDA. This is something that's typically reserved for products that are life-saving products that can prevent significant disease, significant damage, typically things like cancer treatments and the Ebola vaccines and those types of things. This product is the first time anything in dental has ever received a breakthrough therapy designation. So this led to an NIH grant that has funded a phase 3 clinical trial that's being completed in Michigan, Iowa, as well as New York City to gain the clearance for, gain the approval for silver diamine fluoride Advantage Arrest as a caries arresting agent. So that study is currently underway. So to look at the actual chemistry of silver diamine fluoride and how it gets used, the first things to think about are the products that are available on the market. This liquid is relatively inexpensive, normally less than $1 per application. Some of them are a little bit more than that, but it can be found for less than $1 per application. There is a tinted version that makes it easier to visualize where you're placing this material in the tooth. So it's tinted blue, so you can see exactly where you're applying the material. There's also a newly available gel version, which makes it thicker and easier to control. less likely to drip or drop off the applicator brush and stain something. One of the downsides of silver diamine fluoride is if you get it on clothing or if you get it on countertops, it will stain those surfaces black unless you can clean it very quickly. And most of the time in clothing, it's pretty much permanent. Gel is a good way to minimize those accidental drips and drops. It's also a good way to minimize having the liquid be carried to other areas in the mouth after application that you may not want to get the material on. Silver diamine fluoride, as I mentioned before, has well over 300 peer-reviewed literature articles available in PubMed. So you can just do a search for silver diamine fluoride, and you can include any application indication that you'd like, and there will be a good body of research that shows up. It does have a long shelf life as well, so you can purchase a bottle of silver diamine fluoride or some unit doses of silver diamine fluoride, and it has a 2 to 3 year shelf life depending on the brand that you get. Also, a version does not require refrigeration, so room temperature, keep in a cabinet or a drawer. One version has a second step of application of potassium iodide, and this is an attempt to remove the excess silver from the tooth that's not bound to the tooth to help minimize the staining. So there are some different options that are out there on the market currently. The application of silver diamine fluoride is very straightforward. So what you would want to do is choose the site that you'd like to apply it, whether it's a hypersensitive site on an exposed root surface, whether it's a cavitated lesion, whether it's an incipient lesion, whatever the site might be, an interproximal lesion. You want to clean that site and isolate the area with cotton rolls. Then you dry the site. The more dry you get the site, the better it's going to work. And then you want to apply the silver diamine fluoride with a flock tip fuzzy brush applicator. Ideally, you'd want to apply it for 1 minute, but if you can only get 10 or 20 seconds, let's say a squirming child in the chair, or it's just difficult to keep that field dry, 10 to 20 seconds will work, but ideally you want a 1 minute soak on that surface. After that, you would simply blot it away with a cotton roll or a 2x2. Some offices can rinse it away. A lot of offices are actually starting to apply fluoride varnish over the top of those sites as well. Fluoride varnish application can kind of mask the metallic taste that the material has. And then in addition to that, there's a concept or a thought that it may seal in some of that silver diamine fluoride and allow it to work longer on the tooth. We have no data on that. We don't know if that's true, but the concept seems logical. The great part about this is once you do that application, there are no post-treatment follow-up instructions for that patient whatsoever. They can eat or drink immediately, they can resume oral hygiene, and that application is done as soon as you dry off that site or rinse off that site, remove any excess material. The one thing that you will want to do is when that patient leaves, this will hopefully either arrest the lesion or reduce the sensitivity, whichever application you may have used it for. But when that patient returns in 6 months, ideally you want to reapply that material and keep reapplying it every 6 months after that to maintain it. The concept is that site is going to have silver deposited into it, and slowly that silver is going to leach back out, and you want to just keep reapplying it, making sure it stays either arrested or non-sensitive for that patient. So who can apply silver diamine fluoride in the office? This varies by state, so every state has different rules and guidelines that need to be followed. So most states will allow anyone who can apply a fluoride varnish to apply silver diamine fluoride. A small number of states, specifically off the top of my head, Colorado and Ohio, require special training courses before auxiliaries can apply silver diamine fluoride. But the ADHA has a guideline available, and definitely check with your state board. It will be the ultimate say-so of who can apply this in your office. So this isn't something that has to be done by the dentist. It can be delegated to other members of the practice as well. This is a long slide that I'm not going to get into, but how silver diamine fluoride works is pretty straightforward. It's silver and fluoride, and it's not sodium fluoride, it's not stannous fluoride, it is silver ion and fluoride ion free in a solution. When you paint it onto the tooth, the silver wants to precipitate out. And it does that by precipitating out and binding with the collagen structures in the tooth and solidifying them. It also deposits in dental tubules and occludes them. And then the fluoride does what fluoride always does and mineralizes and hardens the tooth and creates fluorapatite. So the short version is silver diamine fluoride penetrates into the tooth and hardens the tooth structure in 2 different ways, both with silver and with fluoride. You may have questions about toxicity. If you hear 38% silver diamine fluoride, that seems like a big percentage, a big number. Well, 38% breaks down to 25% silver, 5% fluoride, and 8% ammonia. 5% fluoride still seems like a decent amount of fluoride, but if you look at the volume of material that's actually used, it's a very, very small amount of liquid that gets used. So if you take the concentration of silver diamine fluoride, which is 44,800 parts per million, but then you calculate that through using the volume that's used and compare it to a fluoride varnish, there's roughly 1/10 the amount of fluoride in silver diamine fluoride in an application of silver diamine fluoride as there is in a typical application of a fluoride varnish. So you have very large margin of safety there. Another easy way to look at it is 1 drop of silver diamine fluoride has the same amount of fluoride as 1 properly fluoridated liter of water. So that's roughly the concentration of fluoride that you would get from 1 dose of silver diamine fluoride. So, okay, using this in your practice, how do we bill for this? How do we code for this? And the answer is there are 3 separate codes that may work depending on the application that you choose. D1354 is the CDT code for application of a caries arresting medicament per tooth. D1355 is the application of a caries preventive medicament. And then D9910 is application of a desensitizing medication. So if you have an active carious lesion that you want to apply silver diamine fluoride, D1354 is the code. If you have a healthy tooth, but it's a high-risk area and you're worried that a lesion may develop there, let's say pits and fissures that are deep occlusal areas, some interproximal sites, buccal pits, those areas you may want to apply silver diamine fluoride, and silver will stay in that surface and on that surface and help prevent tooth decay in the future. That code would be D1355. And it's important to note, you can still do a fluoride varnish applications at these same times. So D1206 can be used at the same appointment while doing a D1354 or a D1355. And then D9910 is used, of course, if you're using it as a sensitivity. The ADA has actually produced some guidelines on how to use or how to code properly for D1355. So if you just search for CDT D1355 ADA guidelines, you'll get the guidelines that you see in the lower right-hand corner of your screen right now. The ADA has also put out evidence-based practical guidelines for non-restorative treatments of carious lesions. And this is a great guide. I recommend you find this, read this article. It will walk through all of the specifics of silver diamine fluoride, and they even went as far as to create chairside guides. They guide you of, okay, here's a primary tooth, here's a permanent tooth, here's a decision tree of when to do restorations, when to do silver diamine fluoride, and when to offer either or both. So it is a great piece of information that I recommend you take the time to download and read. So how to begin using silver diamine fluoride? Choose what you're going to use. Choose the product. Choose a liquid or a gel. Use the gel in areas where you need extra control, or if it's near sulcus where staining other areas that you may not want to get discoloration on is a concern, or areas where you just need a little bit better control. And you choose the case choices that you may want to use this for. Is it a root sensitivity application? Is it a root caries application? Around margins of existing restorations or preventive uses? So there's numbers of different places where you can use silver diamine fluoride. And then you apply it, get comfortable with the material, and then you can delegate this out to auxiliary staff. Again, check with the boards in your state to make sure which other staff members are allowed to apply silver diamine fluoride, and then set up a protocol for the office to follow and ensure that everybody in the office follows that same protocol. Bill it and code it appropriately, as we showed on the previous slide, and then reapply on every patient every 6 months as they return back to the practice to maintain that. So there are numbers of different areas where silver diamine fluoride can be worked into the existing processes you have in your practice. It can be a good protective net or a safety net for the restorations that you already place or that you already have placed. And it can also create some new pathways for your practice as well. So with that, we'll hold the questions until the end, and I will hand this over to the next presenter.
So as she said, I'm Dr. Brooke, and I'm here to talk to you about utilizing silver diamine fluoride in a general practice setting. I typically see patients who have moderate to severe disabilities and geriatric patients, but I also practiced in a general practice before I isolated my practice down to these populations. So I'm going to really try to cater these cases and cater the things that we're going to talk about with you to how we would use this in a general practice setting, and maybe we'll sprinkle in a little bit of special care as well. Disclosures that this is a sponsored presentation. Elevate is sponsoring me for this course, and I appreciate you guys for being here because every time that I get a sponsorship for a course, it helps pay for oral hygiene in a long-term care facility. We have 2 long-term care facilities that we work with, and so thank you guys for being part of this course. Thank you guys for listening, because that is how some of these folks get their teeth brushed. So thank you very much. I also talk about off-label product use of silver diamine fluoride. And I like to say that state laws can vary. So some things that we talk about and some things that our team does, you may or may not be able to do in your state. And that's something that you'll want to check with your Board of Dentistry and your State Practice Act. So even though I do a lot of sponsored presentations, I like to say that I am sponsored but not scripted. Everything that you see in this presentation will be my own patients, will be my own cases. And so everything that you see are things that you're welcome to ask me questions about because they are from our clinic and from my experiences. My task today is to talk about SDF in general practice. So what I'm going to do is talk about what I use it for, how I like to use it, and then give you a few case examples just so that we can see how we're using it in my practice. Jumping right in, I use it as a desensitizer. That's the on-label use of SDF. And it's funny because a lot of people don't use it as a desensitizer because it's so awesome with arresting decay, but it also is awesome as a desensitizer. And this is my hygienist. His name is Vaughn. And when he first started in our clinic, I had him do my cleaning. And then I said, all right, will you place some SDF on my number 3, my number 30, and my number 14. I've got some recession. I do have sensitivity, and I'm a fat kid that loves ice cream. So I had Vaughn place that, and he was really surprised when I first asked him to place the SDF on my tooth. He said, on you? And I said, well, of course on me. SDF is for everybody. You know, SDF works great on our patients, but it also works great on myself. And so it's just to say that we don't want to pigeonhole who we can use this for, and I love it. Like, I'm a fat kid that now can eat more ice cream, so maybe it was a bad healthcare decision for me to do that because now I can eat more ice cream, but it works great. And our protocol when we're doing it, and this is just how we do it when we use it as a desensitizer, is that we try to isolate everything because it's going to stain everything that it touches. So we try to preserve our counters. And then we dry the tooth as much as we can dry it. If the patient is cooperative, we apply it for 60 seconds. So I told him, apply it to me for 60 seconds. Like, scrub it on there for 60 seconds. I promise I'll be as compliant as I can be. We wipe off the excess material because the taste is not delicious. And then I like to put varnish over the top afterwards. When it comes to how often we reapply, I get a lot of questions about how often do you reapply when you're using it as a desensitizer, and everybody is so wildly different. And so when I'm treating somebody like myself or my team or people who happen to be in the office every day that it's really easy to reapply, we just reapply it when we start feeling sensitivity again. So if I start noticing like, hey, I'm getting a little bit of sensitivity, then I'll just ask my hygienist, hey, will you apply a little bit more SDF for me? And for me, that ranges between like 6 months to a year. That's about how long it lasts on myself. For my patients that don't happen to live at our dental office every day, then we apply it when they have their cleanings. If they're having a little bit of sensitivity, even if they're not, we'll say, hey, you're not feeling sensitivity yet? Okay, well, would you like us to reapply it to make sure that you don't? And we'll just let them decide. So our recare for our SDF application for desensitization, it's really hard to pinpoint exactly how often we do it. Our recare for cleanings is also kind of hard to pinpoint because we do it on risk, but we just let the patients decide and we offer it each time they come in. We have a lot of patients that aren't cooperative as well. So with our patients that aren't as cooperative, you can't scrub it on for 60 seconds. That is sometimes Brooke's fantasy world, and I don't always live in my fantasy world. So when we're not in fantasy world where we can actually scrub that on there, we just dry it as fast as we can, apply it as fast as we can, and slap some varnish over the top of it. And when we do that, then we still get good results. Now we can talk about the off-label use. So that's what most people use it for. That's what I use it for most of the time, is non-restorative treatment of caries, so arresting active dental caries. These are the flowcharts from the American Dental Association's paper that they published in 2018. I love that they published a paper that shows SDF as a potential treatment option for non-restorative treatment of caries. I put both primary and permanent teeth on here. I don't see very many primary teeth unless they're retained, but I put it on there just because it was really easy to copy and paste. When we're looking at the permanent teeth, according to these guidelines, they say that it's a good option in a cavitated lesion. And so they're looking at cavitated lesions and saying, hey, this is a really good option. The only thing on there that I'm looking at that is a little bit different is the root surface. With the root surface, they have the 5,000 parts per million fluoride as the optimal treatment with an, if not feasible, than the SDF solution. And I can tell you that I don't really follow that in my practice. What I do is I do both. The 5,000 parts per million in root caries is awesome. And the reason that we like to do that with the 5,000 parts per million and with root caries is because once you've submitted that as a prescription, if that patient lives in a long-term care facility, then now that it's a prescription, people have to pay attention to that every day. And if they're applying that 5,000 parts per million to the teeth every day, they're going to notice that chicken that's been sitting in the teeth. They're going to go in and they're going to have better oral hygiene overall because of those 5,000 parts per million. And I don't know if that's why that is the #1 choice on those recommendations, but that is why I see a lot of success with the 5,000 parts per million in the long-term care facility setting, because it just gives you that attention to the oral cavity that may otherwise not be there when it is part of their medication regimen. But I still treat root caries almost all of the time with the Silver Diamine Fluoride. So here's just some uses. We can use it to buy time. Sometimes we have people that have so many caries that we can't get all of them taken care of in the same visit. In fact, oftentimes that happens where you get somebody and there's just a ton of caries and you're like, I would like to fix all of this right now, but we don't have that kind of time. And so buying time is super helpful. We also buy time to wait for hospital cases. I take a lot of patients to the operating room, and when we go into the operating room, we book out kind of far. And so isn't it wonderful that now I can control the bacterial component of these caries? I can make these caries not be active. They're not still growing. They're not still progressing as we wait for a hospital case. Where previously, as we wait for hospital cases, we just watch those mouths go downhill and downhill and downhill until you can get in the hospital. But now it's like you can push pause and you can wait for that hospital visit. That's the same idea for those of you guys in general practice. Let's say you referred someone out to a specialist and you're waiting for that person to be able to get into the specialist. And whether it's a financial reason they can't see the specialist or the specialist is really popular and super booked out, being able to push that pause button on treatment when you're waiting for treatment is such a valuable thing to offer to the patients. And I make sure I tell them about the staining so that they know what's going on. But just stopping that disease progression is so valuable to me. And that's one of the things that I really like about utilizing Silver Diamine Fluoride, even if it's not the end game for us. A lot of people, when they're working in the insurance world, they have things like maximums, and we have patients that save for care plans. I don't do a lot with the insurance world, so that's not really germane to me. But for other folks, that can be something that can be really relevant in practice. Maybe they're going to get some of their treatment done this year and some of their treatment done next year. And if you don't get it all treated, that's going to keep progressing and get worse and worse. And so it takes a little bit of that, oh my gosh, we can't wait because it's going to progress pressure off, because you're able to control the disease without completing all of the final treatment. It's also been a really good option for me when there's no other good options. I feel like if SDF didn't exist, my job as special care would be so much more difficult, because I wind up in these situations all the time where I have a patient that is too medically complex to sedate and too behaviorally complex to treat in the clinic. And I just think, oh my gosh, if I had to do a restoration on that person, I would just feel guilty all the time because I can't control that disease. And that doesn't seem like it's as relevant in a regular private practice setting, but it really is, because a lot of places in the United States, there aren't an abundance of people who are practicing special care dentistry. There's not a lot of people like myself to refer to. I have people who travel from multiple hours away just because we do special care. We see those patients who have progressed in their dementia to where they have behavioral challenges and they no longer can be treated in the office. And just imagine as a general dentist how great it would be that you're able to do something for that patient while they're waiting to see that person that they may have to travel a few hours to go and see. When I get referrals and the patient's already treated with SDF, it makes me so happy, because for one, they just drove 3 or 4 hours to see me, and I can get something done because those caries are already arrested. Those patients like it so much more, and it makes their dentist look super smart when they come in and I say, oh, your dentist already treated you with SDF. This is awesome. Today we can get these fillings done. And they're like, whoa, what? We can do these fillings? Because I can go ahead and progress on and do those smart restorations since that referring dentist had already arrested those caries. Now, sometimes I have to do another application of the SDF, and sometimes I have to do the SDF when they come, but it's just a neat option to have in a private practice setting when you're referring out to another provider for a situation such as a special care situation. That's the one that I'm most familiar with. But I think it's just really helpful, and I think it's helpful in all stages. There's also end of life care. So we have to make decisions in geriatrics and special care where we think, how long is our treatment plan going to last? You know, and how long is our patient going to be around for? We have patients on hospice, and the last thing I want to do is have their last memory be me or an oral surgeon extracting that tooth, right? And so with SDF, the risks and benefits, that analysis is just so much different because now we have more options. This patient that we see here over on the left, this patient that has all of those root tips that are still in there, he had no pain, he was able to eat, he was happy, and when he passed away, he was totally satisfied. I think had I gone in and tried to take out that canine, that may have been a bad memory for him, and that may have been one of his last memories. So just having SDF as an option is awesome to be able to treat some of these patients that otherwise were thinking, what am I going to do in this situation? It's nice to have that option. This is a cool case that I did just last week, and I thought, oh, I should throw this one in here. We had a patient who had a crown come off. And I've had a little bit of trouble with super eruption of a prep when you're trying to we re-cement a ton of crowns that come off because a lot of our patients don't have the financial means to be able to redo a crown or put another crown on. And so we had this crown come off. She had some recurrent caries. The recurrent caries were below the margin of the crown. So I was like, you know what, so that would have been original root caries. She had recurrent caries under her crown as well. I apologize there. But so when that crown came off, I was able to look at that and think, hey, you know what? I bet I could treat those root caries with SDF, fill it with a glass ionomer, and still have that crown fit. But I didn't want her to leave and then come back like 3 weeks later, have that crown super roughed. It was a porcelain fused to metal. So of course, if I adjusted the occlusion, probably I would have made that porcelain a little bit weaker and then had it chip off and then I look like the bad guy, right? So this is one of the rare cases where I would do on the same day the silver diamine fluoride and the glass ionomer restoration. So I took that silver diamine fluoride and I treated those root caries, and she's a pretty good patient. She's really patient. So we just said, okay, we're gonna have you sit here for a few minutes. And I went off and saw another couple patients. And then I came back and then I went in with a spoon excavator, was able to excavate the active caries in the root caries, and then I was able to place a glass ionomer restoration underneath there. I put that crown back on and tried it on, made sure it still fit. It still fit great. And then I thought, I think I want to treat that whole stub with SDF. And I took the SDF and I treated that whole stub and then re-cemented the crown with a glass ionomer cement. And she was super happy. And we got that all done the same day for her when she came in with the crown in her hand. And I just really like being able to offer those kind of things to the patient, because especially in situations where patients have limited finances and they come in with a crown in their hand, I don't want them to leave with an extraction when there was a chance that I could have gotten a few more miles out of that crown. So that was just a cool situation that happened to come up. I think it was last week. I wish I would have taken a picture of the x-ray to put it on here for you, and I completely forgot to do that, but you can see that glass ionomer where it's a little bit below the margin where those root caries were, and it was totally subgingival. SDF gives me a lot more confidence when I'm doing those subgingival restorations that if there was something that I wasn't able to see, because none of us can really see through the gums. And so when I'm getting down there deep, it gives me that confidence that if there was something I missed, that I'd be able to have arrested it. So that's another cool use. And again, these are all the off-label uses. With the silver diamine fluoride and the glass ionomer restorations, there's a diverse amount of things that we can do with this. These 3 examples here are patients that have a pathological fear of needles, and they weren't able to go into the dentist because they were so afraid of getting numb. And you look at those before pictures on the top and you think, well, there's no way that you're going to be able to get that taken care of without getting numb. And that's true. We did have to do an extraction for one of them, so he did have to get an injection for that one. But we were able to treat a lot of these lesions with SDF, have them come back a couple weeks later and remove some of those caries and get those taken care of without any injections. And so that has been really, really helpful, especially in special care, because that needle sometimes is where you lose that patient. And so when we take that out of the picture, we get so much more success, and the parents love it, or the caregivers, whoever they happen to be, whether it's the parents or the child. They love it because they're like, oh, you were able to do that without the needle? We didn't have to be sedated. And I think that's really helpful in what I do. Now you can see when you look at some of these restorations, you can see that there's some staining, and there's some staining that was under the enamel I couldn't get to. And sometimes that can be with people's tolerances if they're not able to put up with a handpiece, or they can't put up with a high-speed handpiece, or I just missed something. Those are some of the things where you're going to still see those stains shine through. I'm not going to win any awards for aesthetics, but those patients are so happy. Now, some people, you can see some of those restorations that you can't even tell are there. And I would challenge you to take a look at some of Doug Young's work with glass ionomers. Man, he can mask anything. I am not Doug Young. I can't mask anything, but those are what they look like in my hands as a regular general clinician just out there trying to do some of these smart restorations. This is how I do my 2-day smart restorations. I will do the treatment with SDF, and then I'll have them come back. I make them wait at least a week. Sometimes I have them wait a couple of weeks and give that SDF just a chance to be in there and work for a little while. And then they come back, and usually after that one application, it's arrested, or it's mostly arrested, to where I can get in there and I can remove any unarrested caries and place the glass ionomer restoration. I like doing the 2 days because I like to feel hard dentin. Like, I like to get in there and I like to feel that solid dentin before I do the restoration. And so that's why my preference is the 2-day smart restoration. This is the protocol, how I do it, because I don't like to give anesthetic, and a lot of my patients, that's kind of where they fall off the wagon. I'll go in there with a spoon excavator and I'll just gently scrape with a spoon, and I'll ask them how that feels. And then they'll say, oh, that's fine. So I'll say, okay, this one's going to be a little more vibration-y, and I will touch it on their finger, and we'll show them the slow speed on their finger, and we'll say, okay, it's going to feel like this, but on your tooth. And then we put the slow speed in, and we remove any of the soft that we can find. Then if we're worried about aesthetics, then we'll remove the margins that are stained with a high-speed handpiece. Now, that's not always possible in my patient population. Sometimes that hum of the high-speed handpiece is where we lose people. And so we're really careful with who we use the high speed for and who we don't. And that's why I put this picture down here at the bottom. You can see the picture of what it looks like when I'm not able to remove and there is stain around the margins. There's not always stain around the margins. Sometimes the margins look great and you don't have to remove it. But when there is stain around the margins, they don't have to look like that if you can use a high-speed handpiece. And that particular patient, we couldn't even use a slow-speed handpiece. So that is why you have that staining around the margins. But that can be removed when you're using the high-speed. We pumice, we rinse, we use the polyacrylic acid conditioner. We're basically just doing a glass ionomer, following the instructions of the manufacturer on the glass ionomer. So depending what glass ionomer you use, you'll want to follow the instructions on that. And it's just 2 different appointments. It's an SDF appointment and a filling appointment. And so it's really not very complicated. And people ask, well, what do you bill that out as? Well, it's a filling. Like, just because I didn't have to give anesthetic doesn't mean it's not a filling. There was still missing tooth structure that I replaced with a restorative material. It was still into dentin. And so instead of using an injection, I've used SDF, and it's quite excellent in our patient population, and I just really, really love it. And then you can see the rest of how we do the glass ionomers here. These are some of my favorite tools for placing smart restorations. That thing, I think they call it the aesthetic composite tool, but it's this little tiny skinny thing. And we can do interproximal restorations without putting a band, and we approach them from the facial. So if we go right through the facial, we can put that little skinny guy in there and smooth that up, and it's awesome for root caries because you have space to be able to put that little instrument in there and just smooth it out, and it is my favorite. So here's just some case examples. Here's some examples of patients and reasons why we did smart restorations. This patient, she was actually a mom of one of our patients. She was going through a sticky divorce and she wanted to have an implant, but financially, she didn't think she could get an implant at that time. So she wanted to preserve bone. This crown came off, of course, at a time in her life where she really wasn't convenient to have a crown come off. I guess what is, but it was very inconvenient for her to have the crown come off. So what we did is we just treated this little root stub with SDF. You can see they got a perch in there. It already had a root canal in it. And then we just domed it off with glass ionomer, just did a little smart restoration dome so that we could preserve the bone so she could get an implant in the future when she was ready. And that's super applicable to a general practice, because how many times do you have a patient that wants an implant but right now can't afford it, but actually really does want an implant in the future? So bone preservation here was the key to this tooth. It didn't need to be extracted. It wasn't abscessed. It was just broken. We obviously didn't want it to abscess. You can see that big old hole. It's like a bowl, and it looked like a bowl of oatmeal when we got in there, so we had to spoon a whole bunch of stuff out of there. But it's just a really nice option to be able to offer that patient. And then so that we could affordably control the spacing, you know, a couple of options that you would have is to make a little suck down for him to wear at night, like a little bleaching tray. What we told her to do was just get a boil and bite night guard and wear that at night just to help control the tilt of those other 2 teeth so she could still have restorative space for the implant. But it was a nice option that was good for her at that time in her life. And then in the future, she could go and get her implant. Here's another patient. This patient was a patient that was medically complex. He had dry mouth. He came in and he had just a gorgeous smile. And you know, some people have a lot going on in their life and they just can't handle one more thing. And I did not want this guy to have to now lose his teeth on top of everything else that was going on in his life. And so I talked to him about it and we said, hey, these these teeth are probably going to need root canals, extractions. I don't know how long this is going to work, but our goal was just to kick the can down the road until he was in a different point in his life where he could handle a more invasive treatment. Those teeth were vital, surprisingly. Like number 4, you would think there's no way that's vital, but it was. And so we went in there, we treated it with SDF, we put glass ionomers, and I hope he's in a better place in life. I actually saw him a couple more times and then didn't see him anymore. But it was a really neat treatment option for him, and he really appreciated us understanding his social situation, his emotional situation, and being able to accommodate that with doing some really, really basic treatment that went a really long way for him. This patient was medically complex. We were nervous with getting her numb. We were nervous with leaning her back. There were a lot of different things that went into play where we were thinking, that filling's way harder than it looks. So I thought, okay, well, we could do a smart restoration on there and not have to get her numb. And that's exactly what we did. We went in there, treated it with SDF, had her come back, and then treated it with glass ionomer. And we were able to get that taken care of for her, no problem. This patient came in and you can see that number 20, like that tooth is definitely doomed and that tooth needs to come out, but that patient did not want any teeth out, and he was convinced that all anyone ever wanted to do was take his teeth out. He had no trust for dentists, no trust for dentistry, and I don't know why he came into the office, because he like automatically didn't trust me when he walked in the office, but he did. He came in, and then when I told him about SDF as an option, he was like, well, let's do that. And I said, well, we can't do that on this number 20. Like, I mean, that tooth is totally gone. Like, I'll be okay with not taking it out right now, but in the future, that'll be our next thing we have to do, is we have to take that tooth out. But how about we try to save that one on the top? And so we placed Silver Diamine on the top. We had him come back. I guess that's a lie. The very next thing we did was not take that out. The very next thing we did was the smart restoration. But we placed that Silver Diamine Fluoride. We had him come back in. We did those smart restorations, and I actually saw this. This was in like, I think 2017 or maybe 2018, and I had him come in back last week, and those are still holding on. The Silver Diamine Fluoride smart restorations, which I didn't think was going to happen. I thought number 14 was going to need endo, and he was going to have to get that out soon anyway. But at least if we had a relationship, he would let me. But no, that 14 is still kicking right now, which is awesome. And I wish I had a more current X-ray to show you that it's still in there. So then number 20, he came back and he let me take it out. You can see on the other X-ray on the right here, you can see that we sectioned that bridge and we were able to take out number 20 because we established that trust. I met him where he was. We did a treatment that made him see that we valued preserving his teeth as much as he valued it. And then he actually believed me that number 20, super non-restorable, had to take it out. And I think sometimes those things we forget because we have so much dental knowledge that we look at that and we know that it's hopeless. But then a patient looks at it and they don't know that it's hopeless. And if they don't know us and they don't have that trust built with us, we have to earn that trust with them. And sometimes these types of things can help us earn that trust. Another off-label use with SDF that's not quite as popular, but also is wonderful, is that it definitely helps with gingival inflammation. That's something that I noticed when we started using it in the long-term care facilities, and my hygienist noticed as well. That after we treat these people with SDF for their caries and their root caries, they were noticing that their gums were looking better. And I thought, well, there's no evidence behind this, but hey, it works for me. Well, then we started seeing some studies pop up where there was some evidence behind it. So I put a couple of the studies that I read on it, and I was like, hey, what we're seeing actually has some merit to it, that it does help prevent gingival inflammation. So it's kind of cool. Now I'm not injecting SDF in the sulcus for all the SRPs or anything like that, but it is helpful in some situations. And I have put some SDF in some non-resolving pockets and I haven't seen the pocket get better myself personally, but I have seen the tissue be less inflamed and bleed less. So, I mean, take that for what it's worth. It's just anecdotal, but it is something that we've had help us as well. So the other question we get is it safe? So is SDF safe? We want to make sure we don't get in anyone's eyes. It's a basic chemical, and a basic chemical can really burn the eyes. So make sure they're wearing eyewear. One of the rules in our practice is if the patient refuses eyewear, I'm the only one that puts the SDF on. Everyone in our practice can put SDF on. We have our assistants put on SDF, our hygienists put on SDF. You know, I mean, it's like, it's the party thing. We can all do it. We have CNAs that put on SDF in the long-term care facilities. It's awesome. But if they're not going to put their glasses on, it's just me, because if someone's going to get something in the eye and I'm going to get mad at them, I want to get mad at myself, right? So that's the biggest thing I worry about with SDF. And here is just an example of how safe it really is. I took an entire unit dose. I thought, what's the worst thing that could happen? Like if someone were to do it wrong. And I was like, well, if someone got confused, thought it was medication, gave it to them and just asked them to take it orally. So I did it. And here is a video to show you the results of that.
So now we're gonna look and see what happens if I just dump the whole thing in my mouth, which is going to be gross. So you're welcome, because nobody try this at home. It is nasty. So pop the little top off. Here we have it. Okay, this is gonna be really gross. Oh, there it comes. Ooh, ha, gross. Whole thing's on my tongue. Ha. Yeah, that's real nasty. Whew. Feel it in my nose a little bit. Really gross. See a little coat on my tongue? Yeah, I'm gonna get a drink of water because that's way gross.
Really, there's nothing to be afraid of with SDF. The staining, that's the only thing people really worry about. And as long as you talk with your patient and they know what they're getting into, I tell them this is going to stain those caries black, and it's going to be like Sharpie marker black. And then I don't have to worry about it as much anymore. The last couple things that I was going to go over with you guys is just the difference in the SDF products and how I use which one of them in practice. We've got our 38% gel. We've got our 38% liquid. I just started using the gel because it's really new. And whenever I get a new product, unless it's contraindicated, I try it on myself first. So that's why there's no gloves here. It's just me putting it on myself in my bathroom. And you can see here, I'll push play on both of these so you can see them. No need to watch them one at a time. We're just drying it, then we're applying it. You can see the gel there, it's just a little bit more viscous. I can see it a little better. I can see it on the applicator better. And that was something that I really liked with the gel, was that I was able to see myself applying it better. I also had a little more of a strong taste with the gel. Of course, I didn't do this simultaneously. I did them one at a time. And so I noticed with the gel that I tasted it more. And it wasn't because the gel tastes worse. It's because I feel like I was able to get a more concentrated solution to the place where I wanted to get the solution. When I was using the liquid, I feel like I didn't quite get as much in the location. So I feel like you can put more on the carrier with the gel. And this is just my anecdotal information. Like this is just something that I've noticed. Also, I felt like it was easier to apply the gel. I wasn't quite as nervous that it was going to drip down. I wasn't as nervous that it was going to drip on the lip or that it was going to drip on their clothes. And so those were the advantages of the gel. The advantages of the liquid is that I haven't seen much as far as how the gel affects any kind of bonding of a restoration if it was put on the same day as the restoration. I would assume that it doesn't affect the bonding of a restoration doing the 2-day restorations, but if it was a same-day restoration, I would go to the liquid because I don't know much about how the gel would affect the bonding. And I'm kind of picky with restorations. I won't use propy paste or anything like that either on the same day that I place a restoration. So those were the just knee-jerk differences that I saw between the two different products. And my team really likes the gel as well, and they love those little unit doses. So that was kind of fun to try. Don't want to watch those again. And the last thing we have here is just when do I use what? So the big bottle, that's the biggest bang for your buck unless you've got a assistant or a hygienist or yourself that has a heavy pour. And so, you know, you can pour a whole lot of SDF in one of those DAPN dishes and then it's not the best bang for your buck because you just used like 1,000 doses. The triplets, we have 3 operatories. They're small, they take up less space. Those are the ones that our assistants like the best, the little triplets, because they just have a little cute place where they put them in each of the operatories. And then the unit doses, we use those a lot in our portable clinic. And for the gel, we really like that little unit dose. My assistant says, oh, this is so nice. It's just the right amount in just this little capsule. And so we do use all 3 of the different products just for various different reasons. And we were really liking the new gel product. So the last slide is just saying thank you to our team. Everyone on our team does a really important job in the office, and most of the people in these pictures have applied Silver Diamine Fluoride to some of our patients and helped them out considerably. So thank you guys for your time. Thanks for listening to how you can apply these concepts in a geriatric special care and private practice setting.
Hi, I'm Dr. Michelle Kelman. I'm a pediatric dentist here in Los Angeles, California. I am an clinical faculty and lecturer at the UCLA School of Dentistry in pediatric dentistry. I work with the pediatric dental residents, and I'm also an attending at the Cedars-Sinai Medical Center. I personally am a huge fan of SDF. I believe that it really is the silver spoon in the patient's mouth, and I am thrilled to be talking to you about how to use SDF in your offices to help so many children. So right now, what we have is conservative patient-centered care. When you think of children, you have to think, what is the least amount of work that I can do on these children to provide better care? The goal in pediatric dentistry is to make sure that the patient is comfortable, the patient isn't in pain, the patient isn't sensitive, and most importantly, that we've gotten rid of infection, because that's really what a cavity is. It's infection. So conservative care means appropriate behavior management techniques. It means appropriate use of instruments. It also means knowing when to work and when not to. Again, kids don't remember what you try to teach them, they remember what you are. That's a very famous quote by Jim Henson. So it's important to know that if you're going to be working on children, understand them. There's a lot going on right now in pediatric dentistry, from lasers to glass ionomer smart treatment to the Hall technique. But SDF is incredible in the sense that it is able to kill the bacteria and alleviate so much sensitivity. On the individual level, our goal is to prevent disease. On the surface level, it's site-specific. So let's talk a little bit more about that. The AAPD did put out some SDF guidance. Patients who may benefit are those with high caries risk, those that have behavioral or medical management problems, or just with multiple carious lesions. I have found that on my children who have hypomineralized molars coming out, children who have just small cavities, or those that are waiting for the OR, this is really key. And if you have the behavior management techniques to work with these children and you feel comfortable, you're saving them from a lot of discomfort for a very long time. So now there's a child in your office. What do? You need to consider again, and I will keep emphasizing this, conservative quality care. You need to know how to speak with them, how to encourage them. If you're going to be applying a medicament onto their teeth, you need to make sure that they know how brave they are and they know that you're taking care of them. And tell them and show them, no secrets, no surprises. SDF is so easy. No syringe is needed. There's no drill needed. It's basically a drill-free filling. So show the patient with the mirror, show the microbrush, show the cotton rolls. Make sure that they feel comfortable in your chair. So now that the child is in the chair with cavities, what can we do, right? There's so many flow charts out there that are given instructions. This is a really great one. It basically lets you know when to just place some fluoride varnish on, when to perhaps give a fluoridated toothpaste for the home, and of course, when to place SDF, when not to, and when to go ahead and fill that tooth. So for example, if you have a non-cavitated facial lingual discrepancy on a patient, you could put some fluoride varnish there. If it's cavitated, see if you could put some SDF on there, and I'll be showing you more lesions like this. Aproximal lesions, if they're non-cavitated, there's fluoride varnish, there's resin infiltration, sealants alone. These are the types of charts that I recommend you show your patients. I appreciate all of the charts given by Elevate and the AAPD. Laminate them, go old style, and show it to the parents. Say, hey, look, this is why I have recommended fluoride varnish versus fluoride toothpaste versus silver diamine fluoride. So minimally invasive dentistry, it's about recognizing, remineralizing, and then repairing. So you see the tooth, you see a lesion when you're doing an exam. The child is holding the mirror in their hand, and you as a clinician are saying, oh, I see that there's a little germ on your tooth. Personally, I don't love the term sugar bug, but I do use either germ or a little bit of bacteria if they're older, and let me see how I can fix it or get rid of it. Now, right away, the mind goes to shot, drill, but it's your job to show them that there's actually a lot easier things that we can do. So it's great to keep articles around too. This is a great one from Compendium. And it basically says, hey, we've got SDF. It's cleared by the FDA for desensitizing. It's more effective than other fluoride agents in the caries process. And you can give them a copy of these articles as well. This is the chart from the Compendium article as well. And it also says, hey, if there's direct clinical access, you can use SDF. And you can also consider that you can put it approximately through either certain instruments that are out there now or through your super flosser. So when do you afterwards use glass ionomer, and when do you just need to recall? Appropriately, if you can, see them in a week and then see them in 3 months and 6 months. Or if you know you can't see them for 6 months, just know you've applied that SDF and have them keep an eye on it. So how do you explain SDF to a parent? That's one of the biggest questions that we have. How do I not really sell this to the parent, but let them know it's okay? Because when parents hear about metals, they get really worried. So I always describe it as the silver spoon in the patient's mouth. I say, don't you know, when a baby is born, the dream is to have a silver spoon. Because back in the day, they were saying that when you put silver in the mouth, it's an antibacterial. It's going to keep everything clean in the mouth. So that's what we're doing. We're basically using silver to kill off the bacteria. We're using fluoride. We're remineralizing. It's gel now, or you can use the liquid form. I described the percentages. It's 25% silver, it's antibacterial. That's been used for surgeries for a really long time. Then you've got a little bit of ammonia, 5% fluoride, and it is a class 2 medical device. So we know that this is safe to put on your child's teeth. Would I put it on my child's teeth? Yes, and I did. During the lockdown, I was concerned about a little aproximal lesion that I thought I saw. I laid my child down. I put some super floss in their mouth. I put on the SDF and I reapplied it in a week. And I show the patients pictures of this so that they have confidence in what we're doing. I also talk about the zombie effect, the fact that when you've got silver there, it hangs out and it can kill bacteria nearby. And I speak about how fluoride is not dangerous, and we recognize those studies as well. So these are important things to really stress to the parents, especially those that don't have great access to care or are coming from far away. So SDF, we have to know. Semi-annual application is good enough. But of course, I do appreciate putting it on within a week or two as feasible. But as I was saying, some patients come from very far away, or maybe the parents just can't leave work to get the child in there. But we show these studies that biannually can still do the trick. Now, also, you can say that after 2.5 to 3 years, there's been studies that show that there's 70% fewer lesions observed on untreated surfaces when you've got that SDF in there. And it's great to show these photos. So when you set up, and this is the most basic setup, you can make it as fancy as you want. You have to consider everything has to be done in order. We don't want the wrong material being passed. So when it comes to a child in your chair, I like to number everything because you don't know if your assistant's comfortable or if the child will get very, very mobile or if they're medically compromised or have issues with their own behavior or self-control. You want to number everything and you want to make sure that it's easy for the patient. If they can't use a mouth prop, always have a molt there. If they can't have a molt, have your assistant's fingers do the scissor technique, where the thumb is on the bottom arch, the second finger's on the top arch, and it's holding that mouth open. Sometimes even parents help me hold the mouth open. I will flavor the cotton rolls because SDF does not taste amazing and there are concerns about the taste. So you could put a little bit of fluoride foam on there or whatever flavor you use even for oral sedation. So those are some great tricks to kind of get rid of the taste there. Now it may increase salivation a little bit, but it is important. Now your Vaseline too, if you want to put a little flavoring in there, that's fine, but you want to make sure you have Vaseline, you've got your cotton rolls, you've got your mold, everything is set up down to the fluoride varnish. And if you're using the SMART technique, you keep your GI there as well. So super floss, it's great. You can put it on. You can use your micro brush. The new fluoride gel comes with a pink and a blue micro brush, the SDF gel, I mean. And so I sometimes let the children pick now, do you want the pink brush or the blue brush? Would you like to hold one? And so that's a great little fun tool as well. And here's a little video of just how easy it is. Now I've got 2 fingers holding there and the SDF is being placed. Now ideally, that micro brush would not be as close to the commissures there, but we just wait and we wait for it to darken. The longer we wait, the better. 60 seconds is ideal, but if it's 10 seconds in and out, fine. But if we wait 60 seconds here, we'll actually watch it darken. And I appreciate showing parents this as well. I'll say, come over, look, you can see now it's getting darker and darker, which is basically showing me that the silver is doing its job. Your child does not have to have an injection and have to deal with the sound and the discomfort of drilling when I'm placing this medicament on. Now, after this, if you see it darken as we're watching, we'll place the fluoride varnish and then go to the next arch. This patient actually in particular was waiting for an OR for a really long time in their own practice. And we were able to treat all of these teeth without putting the child under general anesthesia. So here are some other examples of occlusals and interproximals. You could see how the lesions darkened right there. And we want to arrest it, right? That's the main goal. So here's how we do it with the Superfloss gel, for example. You could see that when you've got the gel on the Superfloss, it's not going around everywhere. It's not leaking. So I appreciate the gel. I'm less worried about the counters. I'm less worried about cheeks getting stained. And by the way, if a cheek does get stained, you can always use a little bit of makeup remover, especially the makeup remover for waterproof makeup. That will help get that off along with a lot of other products, and I'm happy to answer questions on those. Here's a perfect example. This patient had interproximal lesions in all 4 quadrants, and we used the SDF gel with some Superfloss. And if you look down at the mesial of tooth number K here, you can see how it's already darkened. On the occlusal there, we'd already placed the fluoride varnish, and that's why you see that glossiness. Now, regarding photos in pediatrics, kids are moving. So most of these procedures are done on moving targets, and that's okay. Your x-rays may not be perfect. Your application may stain a little bit on the gum or the cheek because in that area you didn't get the Vaseline. But that's pediatrics. It's moving targets, and your goal is to really just get that dart on. This was a child who was extremely medically compromised and was waiting for an OR for a while. We were able actually to do SDF and place a glass ionomer on top. But if you notice, I don't have any cotton in there. I have fingers. And the reason is this patient couldn't tolerate a molt and couldn't tolerate cotton rolls, but we were able to do the procedure as is. And there's a lot of different examples. Here there's a child, you see cotton down the throat, who is waiting for a very long time for an OR. And we were able to hold off on those anterior lesions by placing SDF. Now, not all parents will accept anterior SDF. And I always tell them, I say, hey, this may turn the teeth black. But if the child is in pain, and you're waiting for this operating room or you're waiting for the procedure to be done and you can either hold off the caries or stop it altogether, you'd be surprised how many parents are cool with it. And then actually we can place glass ionomer on top. These teeth ended up being strip crowns with glass ionomer and it looked great. You can also see that there's a hypomineralized molar erupting on the second photo on top. And we placed SDF on there the moment we saw that it was hypomineralized and there was pre-eruptive caries there. So that's the other thing. You've got 6 and 7-year-olds in your chair, 12, 13, 14-year-olds. First molars are erupting, second molars are erupting. And if you already see caries starting, stop it. Stop this tooth from becoming later an onlay and a crown. You're able to put that SDF on at the appointment, at the recall. And if you've got a child who's really difficult to manage, for example, this is a child who had epidermolysis bullosa. I have permission from the parent to use this. We cannot access inside, so we use the micro brush and we place SDF on all of the molars because they were all susceptible and many of them were sticky and they needed care, but you can't get in there. Here's an example of how a child was already treated with an SSC at a previous practice, came in, the molar we noticed had some lingual decay, cooperation, awful, difficult to get this child to sit still, but we talked to them, we conned them, we showed them a mirror, and here you can see we're just picking out some of that decay right there. There you go. And as we pick it out, we then took the microbrush, placed it on, mixed our GI, and we were able to do it all in one visit. But we saw the lesion turn black, and that's really important. You're noticing when you place the SDF on that it's changing colors. And so would you refer this out? Not if you can manage the behavior. If you see that you're getting a mouth that has full mouth rehab and you don't have access to an anesthesiologist and you're not familiar with strip crowns and you're not familiar with pulpectomies, please don't do them. But you have the ability to stop the caries where they are. So if we actually go and look at this molar here, maybe you're not comfortable with a patient who's so uncooperative. Maybe you're not comfortable with the mobility. Maybe later you are not so comfortable with your SMART technique using glass ionomer. Put the SDF on at least to arrest that lesion and then refer. So again, we're applying a protective coating, we're isolating the area, drying the lesion with a gentle flow of air, applying 1 drop of SDF, wait as long as you can, brush it in with that microbrush as feasible, and then place some fluoride varnish. So here's a perfect example. We put the gel on, and this patient we knew really wanted that restoration on top. So we did 2 applications of SDF. We told the parents there may be a little bit of gray showing through, and then we placed the GI. And if you look, we've got the second molar to do next. So we placed the the SDF on that tooth at that visit. And that's something, again, you can do. The moment you see it, place the SDF on so that it doesn't progress. And make sure you do the fluoride varnish. Now, there is always concerns about this. So it's very important, in my opinion, to put the SDF on and put the fluoride varnish on and keep it all next to each other so that you're not wasting any time. So you keep the SDF in contact with the lesion when you put the varnish on, you're preventing saliva from diluting the area, and it kind of takes away the taste if it's a good tasting varnish. So here's another example. Let's say a mom comes in and she's with her infant, and the infant is nursed, and the infant is developing nursing caries. Here is a patient who right at 14 months was noticing a lesion start, and they took a photo and they sent it to me. So of course, we asked the patient to come in and we place some SDF on there. Sure, there's a black mark. Later we can cover it up, but we caught it right away. And we told them at home to apply fluoride topically right to the area. I gave them a box of micro brushes and I said, just apply this fluoride toothpaste directly to the lesion. And so let's say that you have a variety of caries that you're looking at. So there again is that number A that we were looking at. You see a little bit of lingual, apply it, you see how the black forms right away. Let's say you've got a second molar there and you don't feel comfortable using a syringe and a drill on the patient. You want to refer out to peds because of the behavior. So place some SDF on there, hold it over, because not every patient has a pediatric dentist living right next door to them. So be as minimally invasive as you can. And perhaps you'll do 2 SDF treatments and you'll take a radiograph and you'll see, hey, I don't even need to refer out for this. I can just keep an eye on it and perhaps then restore it with some GI. But again, if you don't feel comfortable, do refer out. Now, here's a child who had an extreme amount of sensitivity. So we did use, of course, SDF for what it was FDA cleared for as a base for sensitive teeth. There was here hypomineralization. We know about MIH now. We know about the benefits of SDF on those teeth. So feel free to put SDF on there. The immediate reaction should not be, this is a hypomineralized molar, so I need to, because this patient has behavior issues or has any type of medical concerns, or maybe it's just really wiggly in the chair, that I need to immediately send it to a pediatric dentist to put a stainless steel crown on this. No, because guess what I'm going to do? I'm going to reapply the SDF and hope that I can just restore it with GI and keep an eye on it. So there's another example. We've got a patient who's highly mobile, uncooperative. We've got this hypomineralization. We put SDF on the tooth. We cleaned it up with some GI. There's no cotton rolls in there. The kid was all over the place, but we got it done. Right here, you can see that we were able to get the suction in. We were able to hold it over. We saw the lesion turn black. So again, if the patient is cooperative, put those cotton rolls in, put the mouth prop in. I specifically have a photo here of the mouth prop moving around by the tongue. The point is the SDF got on. So if we're going to place it, you want to look for the black. Here's an example of how we use the mold, because the patient wouldn't keep the mouth prop in, and we flavor that as well. And again, just scooping it out. There's the hypomineralized tooth. Silver Diamine Fluoride is recommended for teeth with MIH. You're going to see more and more teeth with MIH now. They're sensitive, and that is one of the main reasons they're referred to pediatric dentists. The child just has sensitivity eating. But we're hoping that in your office, when they come in the general dental office, if a mom says, hey, can you take a look at his back tooth? It's really uncomfortable. Right then and there, you could put some SDF on it to hold it over. And here's again, it was mobile, but we were able to get some GI on there as well. We're going to keep an eye on it. Later, we'll put a crown on it if needed, but we're able to mask it right now. So looking at these teeth, knowing that it's an ongoing caries management plan, it's important to keep this in your toolkit, okay? You can do same day. This child had nitrous, as you can see, and we were able to really keep the patient calm and do a whole quadrant. One drop can go for 5 teeth. So, I'm sorry, one carpule can go for 5 teeth. So here we go. We're gonna rest it, and then we're gonna see, what can I use this for? So who? Pediatric patients, phobic patients, special needs patients, adolescents. We're looking at hypomineralized teeth. We're looking at sensitive teeth. We're looking at that small cavity that you think you'd want to fill, but the goal is you want a painless, very comfortable, atraumatic, minimally invasive toolkit to treat your pediatric patients. Make them be a part of the dental home that you've created for them. They will have faith in you. They will understand why you're doing this, and make sure the whole family is involved. So thank you very much. If there's any questions, please feel free to ask them.
Thank you guys all for a great webinar this evening. And we have had quite a few questions come in. So we're going to start off with Dr. Brooke, a question in for you. I know you discussed a lot of the different uses around silver diamine fluoride, and there's lots of questions coming in about staining. Can you kind of discuss what you should expect to stain and what will not stain on your patient? Or Dr. Kelman, either one of you can unmute yourself, and we're just looking about staining. Hey, Dr. Kelman.
Can you hear me?
Yes, and Dr. Kelman's suffering from a little laryngitis tonight.
As you can tell, it was raspy, but it's getting raspier. So regarding staining, of course, the main goal is that we're removing infection, right? And that's the way that we see that the infection is gone. So if the stain is bothersome to the patient, I'm so sorry, then we're going to place a little glass ionomer once we know that the decay has been arrested. In terms of stain left over, if stain is left over on the face or on the body, I recommend using makeup remover, like I said, waterproof makeup remover. If it's on the counter, anything ammonia-based, any type of Clorox wipes, it's great to get Clorox wipes on there right away.
Perfect, thank you. And then can you clarify, Dr. Kelman, if you're using silver diamine fluoride for hypersensitivity or for prevention, would you expect any staining on those two surfaces?
It's interesting, I usually do. I see it right in the grooves that are the most hypomineralized, but not always. You will see it if, for example, because the area is hypomineralized, it has become more susceptible to plaque and to bacteria settling. And so you will see some staining in the region at that time, but not always.
Okay, perfect. Thank you, Dr. Kelman. And Dr. Brooke, I think we've got you back on here. Feel free to unmute your microphone at any time.
Yeah, sorry about that. I had to pop off for a minute because my phone decided to just shut off the volume and all the picture, but I got back on. So
Perfect
thank you.
timing. Yeah, thank you. Okay, so Dr. Brooke, we were just talking with Dr. Kelman about staining. When you're using this on like root surfaces for sensitivity with patients, do you see any staining on those areas?
I would agree with what she said. Is sometimes you can see those hypomineralized areas where you can see a little bit of staining with that as well. But most of the time on the root surfaces, I'm not seeing it as much, but I have seen it. And I have seen it to where it'll stain the root surfaces quite dark. And so I talk to them about the worst case scenario. So then that way, if it doesn't stain, I'm awesome. And if it does stain, it was expected. And so we do go in with the assumption that it would stain.
Perfect. Okay, great. And I saw a head nod from you, Dr. Kelman. Thank you. So with that kind of leads into the next question here that was asked is, would you recommend an informed consent form when you're using this with your patients?
I definitely would. I think it's very important to discuss all of the risks, all of the benefits, risks being perhaps the staining, and of course, if the taste isn't what they were expecting. But I do think that it's very important to also give them the informed consent form because it is treatment the same way that you would do for your fillings or for your root canals or anything else.
Yeah, I totally agree. And I think my assistants would probably laugh at me for that because I am the worst at paperwork. Like I forget my informed consent form almost every time we do it, but it's a good thing I've got great assistants because I start getting everything and I'm ready to go in. They're like, hey, we should do the form first. So if you're a doctor like me that forgets paperwork all the time, it's really good to educate your team and so that your team can keep you on track and can make you do your informed consent. Because I can definitely say I need a babysitter with informed consent. It is very important. I forget it every time. So having those team members to be like, hey, Dr. Burke, stop, let's get the paperwork done. I talk to them, of course, so that they're informed and they know what's going on, but I always forget to do the paper. So having your team be able to be there so you can actually have that documentation, I think is important.
It's a good idea with pediatrics to also have the pictures there. So if there is going to be staining, then and you have the pictures provided by Elevate also, there's a great guideline. Then they'll know what to expect so they won't be too worried. I had a patient once who started crying after the SDF, spit all over her leg. The mother called me that there was stains all over the leg. I was very happy that I had done an informed consent, letting them know about the staining because I was able to reference right back to it and they had a copy of it.
Sure, that makes sense. Great advice, you guys. Thank you. Okay, other questions that came in were around bond strength and does silver diamine fluoride affect bond strength with either glass ionomer composite or anything?
So there have been some studies regarding bond strength, quite a few actually, that I am happy to give references to. I have not found SDF to have an effect on bond strength. I've been able to, not at the initial visit, unless it's with glass ionomer, but I have been able to place strip crowns over, etching and bonding, and well, preferably not etching, but bonding and then using the composite to bond. So I haven't found any concerns with it.
Yeah, I haven't found any concerns either. I actually find more concerns when it comes to bond strength when I get my lesion contaminated because I work on a lot of wiggly people that are bigger than me. And so I find that I do have restorations that come out. And so when I see that, I don't attribute that to the SDF. I attribute it more to having saliva contamination because that happens on my fillings that I don't put SDF on as well. And so when we have things come out, it's mostly my isolation.
Okay, great. Thank you. We got quite a few questions in as well coming in about really the depth of the lesion. And I know you both, as well as Steve, shared the ADA's non-restorative treatment guidelines, and it kind of really breaks it down in there. But as far as the depth of the lesion that you can treat with silver diamine fluoride, are any lesions too deep? And is it safe if there is pulpal involvement with the tooth?
I've personally found that if it's indirect, it's generally biocompatible to dental pulp tissue. So if you put it right in the pulp, there's been studies that have shown necrosis, others that are a little bit more promising. But I think that as long as you stay above the pulp tissue, at least in pediatrics, we feel safer. I'm not too familiar or haven't had as much experience going closer than that, then you are actually going to see an increase in odontoblasts, an increase in tertiary dental formation, and a very mild inflammatory response. But it is going to kill off the bacteria at that level.
Yeah, and I would say that it really depends on the patient. When you're working in geriatrics and special care, sometimes in geriatrics, I mean, where is the pulp? You know, you're looking at that pulp is receded so much that you can treat lesions where those are just decayed down to the gum line. I had a couple of pictures where you saw the decay down to the gum line, and we were treating those with SDF. I have had one case where I treated a real lesion where we did have some post-op pain, and it does happen. It doesn't happen very often. I treat a lot of really deep lesions with SDF, and typically I don't have troubles, but I have had one, and the one that we had a trouble with, we ended up extracting, and I took a 557 burr and I was able to section that down, and I was able to look at it, and it did travel. And I do think that the SDF did get into the pulp in that one situation, but as with any technique, there are going to be some failures at some time, and I have put SDF in super deep lesions. I've not ever put it directly, as you were mentioning. I've never done it as a direct, but I've put it as indirect pulp caps. I've had it where it's like, okay, I'm going to put it really close. I'm not going to dab it right on the red spot, but I'm going to go around the rim, you know. And so I've done a lot of them and only had one that failed like that.
Okay, great. Thank you, guys. Lots of questions as well about SDF being effective for secondary caries around existing restorations.
So I have definitely placed it around existing restorations. I think that instead of going in, if you're seeing that you don't have recurrent decay underneath the restoration, meaning you don't have to remove the restoration, if you have decay going into the grooves around it, absolutely you can place SDF into there. I mean, there are very few areas that if I see any form of decay, I will not place SDF into. And I reinforce this to the parents in the practice in the clinics that that is our way of making sure that it doesn't get any deeper, that we don't end up putting a bonding on top of that, or bonding as they call it, and that we don't need to, at a later point, need to use an injection or a drill. That's more or less the take-home message in pediatrics. This is our drill-free way of doing it. So absolutely, if I see decay around an existing restoration, if a parent allows me to, I will place SDF there.
Yeah, I would second that. I would say all the time. I'm always putting SDF, and it's not only a recurrent decay around a restoration. When you see those crown margins, that we see a lot of patients that are from various areas, and some of these patients have some crowns that are really questionable. But do I think I can do a better job? Sometimes not, because sometimes this is a moving target, and that crown may be the best thing that they have on there. And so as I'm looking at some of these crowns that have these open margins, or that have these overhangs, or that have something questionable that I don't feel like I can repair at the time, I'll put SDF even when there's not recurrent decay, because I want to prevent that recurrent decay. And I would say that I do that more often than not, especially on long spanning bridges. When you're looking at a geriatric patient, you've got this long spanning bridge and you see this open margin, and now they've got dry mouth. Like, let's make that bridge last the rest of their life by sticking some SDF in that area and not getting recurrent caries. But sometimes I'll even take it under recurrent caries, and if I think those caries have penetrated, then I'll patch that restoration. I'll go into that restoration a little bit with a handpiece and patch that restoration and try to get more longevity out of that restoration.
Great, thank you. And then can you guys remind us just how frequently silver diamine fluoride should be reapplied?
So I prefer to reapply it if the caries has not arrested. To be perfectly honest with you, I think I'm going to need SDF after this. I'm about to put honey. Go for it.
Yeah, no, I would definitely agree. I like to make sure that the caries are arrested, and I'll reapply SDF until it's arrested. But then also, I vary everything, and everything in our practice is varied based on risk. And I think that insurance has gotten us into these pigeonholes where we're like, I must do X, Y, or Z, every X, Y, or Z. And then we always try to find guidelines, but who are those guidelines proving things to? We're trying to prove things to a third-party payer that they're supposed to pay us to do this less frequently, right? And so I feel like when we're looking at how frequently to apply things, the most important thing is how successful is this in this individual patient? So I know that's a terrible answer to your question, because you definitely want a number to that question. But what I do is I will check in a week. And if once it's arrested, I'm going to see that patient again in 3 months. And I'm going to look at it. And I'm going to say, hey, 3 months was great. Are we going to reapply it? Yeah, because it's cheap and you're in the chair and my barriers to the chair cost more than the SDF. So I'm going to reapply it. And then we're going to have you come in, let's say 4 or 5 months. And then we're just going to space it out and space it out and space it out until we get to a point where we say, okay, now we need to do it more frequently than that. We do that same thing with our cleanings. We do that same thing with any kind of recare. We just try to push them to where they don't need any more frequent treatment. And so we try not to have too many regular intervals for things with that, if that makes sense. So sorry for the terrible answer to the question, but I would say on average, when my patients needed it is about a year out.
So with pediatrics, sorry, Brooke, I agree with you. And with pediatrics, the thing is, I would prefer to see the patient in a week or in 2 weeks to see if the SDF is working and reapply then. But again, that's not always possible. The more frequent we see a patient in pediatrics, the more we desensitize them emotionally, mentally, if it is such an easy procedure. So they come in freaking out and we're just applying a drop of SDF to the tooth. They're going to know that the next time it's just that little brush they held being applied to the tooth. So parents don't seem to mind as much once they see what a harmless procedure it really is. But there is no exact number. It depends on the condition of the tooth. So 1 week, 2 weeks, if I see that after 2 weeks it hasn't gone away, I'd say, okay, come back in a month, come back in 3 months. And then I like to reapply it at their dental visits, whether it's every 3 months, every 4 months, every 6 months. Like Brooke said, the dental cleanings, that's an imaginary number, right? Every 6 months. So we try to get them in when they're high risk, at least every 3 to 4 months. And if we see that we need to reapply the SDF, then we do.
Awesome. Great. Thank you guys so much. You guys both have just done a great presentation, each of you, and then just taking the time to elaborate on some of these questions has been great too. So thank you guys both for your time this evening, and for all of our listeners on, thank you all for joining and spending your Tuesday evening with us. To our guests, again, we just want to thank you all for hanging on a bit longer than this event was originally planned for, but we hope that you found the abundance of information useful. And just so you know, you will all be receiving 1.5 CE credits rather than our original plan of the 1 credit for this evening. And that certificate will be emailed automatically within about an hour or 2, so be sure to check your spam folder. Also, you can follow us on Facebook and Instagram for links to new free CE events. And the link that you see on your screen will give you access to our archived webinars, including this evening's webinar, which should be accessible in just a few short weeks. So please share this link with your staff and colleagues. And finally, on our Elevate Oral Care website, you will find buttons to request an informative CE-eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with you and your team and help you best serve your patients. So thank you all. Have a wonderful rest of your week, and we hope to see you on our next Elevating Care webinar.